Again, I'm Dr. Khalid Waliullah with Columbia Orthopaedic Group, and I'm going to give you a webinar about precision joint replacement today. So first, I want to talk to you a little bit about my journey and kind of how I got into orthopedics and why I am here today, kind of introduce myself to the community some, and then I want to talk to you about sort of anterior hip replacement and robotic knee replacement and how and why I think that combining that with image-based navigation and gap balancing really can make a big difference for patients, and why it's important to me, and why I think it's the right way to have surgery. So hopefully everyone can see my screen and everything is going smoothly on that side of things. So my journey about me, I grew up in Augusta, Georgia. My father was in the Army Corps of Engineers, and we moved all around the world when I was little, and then we settled down in Augusta, Georgia. I went to elementary, middle, and high school there, went to college at Mercer University in Macon, Georgia, and then went to medical school there as well. I moved to Missouri in 2011 and have been here since. Met my wife here. We've kind of settled down here because of that. Went back to fellowship in 2023. I've been board certified in orthopedic surgery since 2018. And hip and knee replacement is all that I do. All kinds of hip and knee replacements, partials, totals, revisions. That's sort of what my day-to-day life is like, and kind of what I'm really interested in. And then beyond me, there's my family, my beautiful wife, and 2 kids. That's a picture of us in Stone Mountain, Georgia, where my parents live, just at spring break. And they kind of helped make this all possible and also worthwhile for me. So kind of my road to precision surgery, in undergraduate college, I was a biomedical engineer, and that's where I really kind of fell in love with mechanics and computers and sort of trying to understand how those things work together in the human body. In medical school, I really started to see that I enjoyed surgery more so than the other areas of medicine, and orthopedics specifically. I went on after I graduated from residency to practice orthopedic surgery in Southeast Missouri in Cape Girardeau for about 7 years. And I thought this was a really important time in my life that helped me learn how to do sort of conventional surgery, and learn how to try to take what we learned in residency and put it into practice. And it kind of became apparent to me at that time that although we're really good at knowing and theorizing about things, the actual doing of the surgery is a much more difficult thing to translate it to. Sometimes we talk about in textbooks, you want to try to turn this part 3 degrees this way or 6 degrees that way. And that's something that's easy to say, but really very difficult to do. The human eye can only see about 2 to 3 degrees. Anything smaller than that, we're sort of guessing that we got it right. After my time in Cape Girardeau, I really started enjoying hip and knee replacement, and I wanted to go do a fellowship to make sure that I was doing the best possible job when I did those procedures. So I went back and did that. And then I've been in practice at Columbia Orthopaedic Group for about 2 years now. That's where my sort of interest in robotic surgery and navigation has really set hold. And I feel like this is really the best way to do things. So in my clinics, I think that no 2 patients are the same, and that's why no 2 surgeries should be the same. At every visit, we want to make sure that we're addressing your goals, and that our treatment plan is kind of tailored to you. Before surgery, we get advanced imaging, meaning either a CT scan, sometimes an MRI, and sometimes just some special x-rays that we can then use to plan your surgery. And then in the operating room, we use these tools that I talked about to make sure that what we're planned is what we ended up doing. And it gives us real-time feedback so that we can make changes if we need to, as opposed to finding out later on that, boy, we wish something was a little bit better here, a little bit better there. I think it's nicer when we can do that right away. And then after surgery, we kind of train or tailor the recovery process to you. Some people are really high demand, highly active people, and they may have different goals than somebody who's really struggling to get around prior to surgery. And we got to keep all that in mind, and we can't just give everybody the same physical therapy prescription and the same, expectations. So, we always make sure that surgery is what you need. There are lots of other things that we try first. I think the what I tell patients is that, if you're having pain every day, you can't do the things you want to do. It's hard to do the things you need to do, like taking care of yourself and taking care of your home, and you've tried everything else, then that's when surgery is a good option. And tried everything else means things like anti-inflammatory medicine, maybe the right kind of therapy, steroid injections, maybe depending on what's going on, bracing sometimes, looking at sort of the rest of your health and your weight, and trying to make sure that we've done everything we can. Some people come and see us and they've already sort of far enough along their journey that those things are not really a good option for them. They're not going to be successful. And other patients are sort of just in the beginning and they may never end up having surgery. And so we see the whole spectrum. And just because you come to see us doesn't mean you're going to have surgery, but it is one of the tools that we have. And so before I get too far into this conversation, I want to talk about two different things here. One is precision. We talked about that's the title of this talk, is precision joint replacement. And precision just means that you're hitting really close to the same spot. And it might not be your target, but if you look on the right side of your screen here, that bullseye with those points in the top right, that's a very precise area, but we didn't quite hit the bullseye. And then on the left side, they're pretty accurate. They're closer to the bullseye, but it's not very precise. They're all over the place in terms of where the spots are at. So we want to combine those two and be accurate, but also be precise in what we're doing. So first we'll start with anterior hip replacement and how image-based navigation I think is really important. So what is total hip replacement? Well, basically what happens is that the hip joint, which these pictures kind of illustrate on the far left, is what a normal hip would look like. And then in the middle, kind of what happens as hip disease builds up. And then how do we treat this? We treat it with the metal and plastic replacement. And when I say hip disease, it's because there's a number of different things that can lead you to the path of needing a replacement. At some point, trying to repair some of these things is just not successful, and the long-term outcomes aren't as good. Hip replacement surgery has really excellent long-term outcomes. And so sometimes that's the final sort of decision that people end up with, regardless of their problem of how they got there. And there's different ways to do a hip replacement. I do both the anterior approach and posterior approach to hip replacement surgery. They both have their pros and cons. The incision is really sort of where the difference is at. One comes through the front of the hip, the other through the back. And through the front, we're able to sort of spare more of the muscles than we can from the back. But I think the big difference here is that we don't have to worry about hip dislocation from the front. Not that it never happens, but it's so extremely rare that we don't recommend that people have hip precautions on a routine basis after having an anterior approach surgery. Where posterior approach surgery, we still have some hip precautions that we keep in place. And down the line, years down the road, those are still sometimes come into play. Whereas with the anterior hip, we kind of don't have to worry about it. The other thing that I think is really important is that we can get better x-rays when we do an anterior approach hip because you're laying flat. Whereas when we do a posterior approach hip, you're laying on your side. And that little difference makes a big difference in the quality of the images that we get during surgery to help us judge how long your hip is and how wide it is. Offset is something that we use as a technical term, but really it just means how wide your hip is. And so, image-based navigation surgery, what it really means is that we get really good quality imaging of your hip beforehand. We make sure that it's perfect so that when we are in surgery, we can compare our pictures to what you had beforehand. And when we've planned your surgery, we look at, okay, did we end up exactly where we said we were going to be and what we thought was best for you? We can confirm that. So just understanding what I mean by leg length and offset. Leg length, I think, is fairly easy to understand. It means how long is this leg? Well, we really can't control more than what is happening at the hip when we do a hip replacement. And so, well, the way we measure this is from some landmarks where I don't know if you can see my cursor on the screen, but there's these little red U-shaped areas. We call this the teardrop. And we draw a line flat across your pelvis from there and then down to these red bumps here. This is called the lesser trochanter, and it's what we use as the landmark to measure your length. And then offset is basically how wide are your hips. And so we kind of look at the distance between your pelvis, which is this ring-shaped bone here, and your hip, just above the lesser trochanter. We kind of draw a line there and we look at it. And everyone is different, and so we want to make sure that we're recreating these things. So if we look at this X-ray here, this is of somebody who has arthritis in their hip on this right side. In medicine, we flip the labels, even though when we're looking at it, it's to the left because it's the patient's right hip. That's what we call it. And we can see that as this hip has gotten arthritis, the joint space has gotten less. And so now the right hip is shorter than the left side. And in this case, the offset is relatively unchanged, but it can change quite significantly. Now, if we look at this X-ray here, this is of somebody who's had a replacement, and we can see just by looking at this hip X-ray, you would say it's not real symmetric. The one side looks different from the other. And if I draw a line here, again, across from those teardrops, then down to the lesser trochanter, we can see that one of these lines is much longer than the other. And so this hip is longer on this side. But the other thing we notice is that the offset is off. It's much wider than the other hip is, and that can cause pain and dysfunction as well. This is now looking at the left hip, and we can see that, again, this left hip is both longer, and there's a difference in the offset as well. It's not as substantial, but it's still there. This is looking at a hip replacement that we did where it looks like that I did, that we can see what did the patient look like before surgery and what did it look like after surgery. Here you can see that we did a really good job of recreating their leg length and their offset. And so navigation helps us ensure that we're not only making it symmetric, but back to what you had beforehand. So why leg length and offset matters? Natural gait, it really just helps you walk better if you have equal lengths of your legs. And it helps with implant stability. So when we talk about the hips dislocating, if we have the length right and we have the width right, it helps make these implants stable and helps keep them from wearing out. And having a correctly balanced hip means faster return to walking, stairs, doing things that you want to do, and then strength. So we call it abductor strength. Those are the muscles on the side of the hip. The correct offset sort of restores those better than if we make it too wide or not wide enough. And so we want to make sure that people don't have a limp, and that's made more likely to be the case if we get things back to where your natural length is. And patients, the biggest reason for people to be, or one of the main reasons people are unsatisfied with the hip replacement is if their leg lengths are off. And the risk for revision goes down as well. So what does the research show? That more than 96% satisfaction with hip replacement outcomes. We can get your leg lengths to within 4 millimeters of each other, sometimes less. That we shoot for even, but 4 millimeters is so small that even in that case, typically it's not noticeable. Most people return to walking without using a walker or a cane by 2 to 4 weeks, and the rate of dislocation is extremely low. So then we're going to move on to robotic knee replacement and gap balancing. So before I talk about robotic knee replacement, I just want to kind of touch on what did we use before we had that. Well, we used what we call conventional instruments, and those are things like you see here in this picture where they're sort of jigs and outriggers, if you call them, if you think about it that way, that we put on the leg during surgery, and we try to pin them into place or hold them in place. And we're kind of looking at these and trying to judge, is that right or is that not? In robotic knee replacement, we get a CT scan beforehand, sometimes an MRI, and the computer can use that to know sort of where is this knee in space, and then helps us position or change the parts and size the parts perfectly every time. The robot itself is on the left here, and all it really is an arm that has the saw connected to it, and that won't let us move this in a way that would change the alignment. So we're still doing the work. What the robot is not doing is it doesn't operate on you. It doesn't replace surgical judgment. It doesn't take the place of experience to know that you're doing the things the right way, because we still have to put the parts on and we still have to move the parts around without the robot's help. But it does give us, really good real-time information about what are we doing right and what are we doing wrong. It lets us check the tension in the ligaments and make sure that we're doing it correctly. The analogy is that of GPS. GPS takes the place of a map, not of the driver. So we're still driving the car. The robot just gives us the right map to make sure that we're going in the right direction. And so what's gap balancing? There's a lot of different theories about how you should do a total knee replacement. And one of the big things that we look at, no matter how you do the replacement, is it stable? Is it symmetric? And what we're looking at when we say that is the space in between the thigh bone and the shin bone when the knee is bent and when the knee is straight. If we make it where there's no space at all, it's going to be so stiff that you won't be able to move. So we have to leave some space available. And naturally, we have space in between the two bones too. So we're trying to recreate that. We know that an unbalanced knee is painful and people don't like it. If you're stiff when you're straight and loose when it's bent, that doesn't do well. The robot helps us measure the tension in the ligaments instead of just eyeballing it or feeling it. And then we can say, okay, we need to take a little bit more here, or we need to do a little bit more there to get things feeling natural and balanced. Robotic versus conventional knee replacement, there's a lot of good science behind why one might be better than the other. It's still something that's relatively early in its use, and so we don't have definitive proof that we say you got to do it this way. But we do know that when you do things manually or with conventional instruments, there's about 2 to 3 degrees of error. With the robot, it's 0.08 degrees of error. And so that's a really big benefit. And then we can really feel the tension when we're doing it conventionally. With robotic surgery, we can feel the tension in the ligaments, but we can also measure it. And so really this helps us do, I think, a better job. And so the benefits of robotic gap balancing, what does the evidence show? The studies that have been done show that, robotics measures your ligament tension. We have better functional scores. So what that is that people that have surgery, we ask them, how do you feel when you do X, Y, and Z, and rate it on a scale of 1 to 10. And we give those patient-reported outcome scores to patients. Routinely we see that there's a better outcomes with gap balancing versus some of the other ways to do it. And then the robot really helps you do that with extreme precision. So gap balancing, we think, is more accurate, and then the robot gives us the ability to be more precise. So again, kind of looking at some of the data that's been out there, it shows that the scores of these patient-reported outcomes are higher. When we look at big studies that have been done over big populations, we see that knees do better when they're gap balanced. And after conventional knee replacement, this is some older data from 2007, shows that about 20% of people were still unhappy. And so we really had to, I think, make some headway in figuring out why and how do we make that number less. And that's what I think robotics combined with gap balancing does, is it helps there be fewer patients that are unsatisfied or unhappy with their outcomes. So, when you first come to see me, we go over your x-rays, we talk about your goals, we talk about your health history, we talk about what do you want to do. A lot of patients are in a position where, they don't need to have surgery right away. We can try things like injections and medications and bracing and therapy. And we keep doing that. So we kind of stay at step 2 until you tell me that, this isn't working for me. I need something better than that. And that's when we start saying, okay, let's get some different imaging. We may get a CT scan or an MRI, and we get you set up for surgery. And then on the day of surgery, that's when we sort of try to execute what we planned and try to make sure we do it as accurately as possible. So really, I think that precision plus personalizing this, is a better outcome for each unique patient. Just like we're all different on the outside, everybody's needs are different too, and that I think has to be something that you think about. So, why I think patients choose, our team here is that we're all, fellowship trained at Columbia Orthopaedic Group. This is what we do day in and day out. We'll take the time with you to make sure that we've got the right plan. We have access to some of the most advanced technology out there to help make sure we do the job the best we possibly can for you. You'll always be able to get in touch with us, and we have some of the best outcomes, in the region. I think getting you back to life, to the things that you want to do, is what our goals are going to be as well. So our goals are aligned to help you do better. So some of the common myths about joint replacement, that you're too young for joint replacement, that used to be the case. This was a surgery that was initially designed for people in their 80s because they didn't last very long. As we've gotten better and the technology is getting better, the implants have gotten better, we're now, that age is coming down less and less. Staying active matters more. And so we often operate on people in their 50s and sometimes even younger. But those are, for specific cases. Recovery takes forever. I would say with the anterior approach, everybody is walking the day of surgery. Most patients go home the same day, depending on what your overall health is and how your home situation is. Knee patients are often driving within 4 to 6 weeks, not using anything to help them get around. The myth that all joint replacements are the same, it's similar to the fact that all people are different. Every surgery is different. The approach, the technology, the amount of experience somebody has, the type of replacement that they're using, all these things affect your outcome. And you really want to find where all those things are working together for you, as opposed to one thing from here and another thing from over there. Joint replacement being the last resort. I typically want patients to try conservative treatment, but it's oftentimes that by the time they show up in my clinic, they have, or their problem is so far along that it's unlikely we're going to be successful. And so, if we do end up having to have surgery, it's an option that's proven to do, a really good job. And it's not a failure if you end up having surgery. It's more so just another tool. And then we talked about the robot not doing your surgery. And then also, the fact that implants last as long as they do now, it's unlikely that you're going to have this revised or redone because they wore out. Again, some frequently asked questions I thought would be important. Most patients go home the same day or the next morning. How painful is recovery? Everybody feels pain differently, but we have some really great tools now to help with pain control after surgery, and we're constantly looking for new ones. There's some new medications that have come out recently, some new techniques that we've been using that makes a dramatic improvement in how patients feel pain afterwards. Patients often ask, can I go back to playing sports? You'll be back to playing golf, swimming, pickleball, cycling, those sorts of things. When you're healed, certainly is doable. High impact activity, like if you said you want to go running or skiing, we'd have to make sure that was reasonable. And but there are patients who go back to those things. You don't have to be put to sleep. People often ask, like, do I have to go all the way to sleep for this? Most of these we do with the spinal, which is similar to having like an epidural that patients may see during pregnancy or in labor. And it does really well in terms of limiting how much nausea and how much pain you have after surgery. When can you drive? If it's your right leg for hips and knees, it's a little bit different. I want you to be able to stomp on the ground without pain, and I want you to be able to not have to take pain medicine, and that's somewhere between 2 to 4 weeks for hips and 4 to 6 weeks for knees. New implants, they don't really typically set off metal detectors like they used to. And so it's not really a complaint we get from patients anymore. And then, are you a candidate for anterior hip replacement? Most people are, but we want to do what's safe for you. And just like I said before, that not every patient is the same. We also shouldn't just blindly go with something that may be harmful to you. So we would look at your BMI, your medical history, and we would talk about whether it's a good idea or not. So with that, I just want to say thank you guys for taking the time to listen to me talk about hip replacement and knee replacement, two things that I'm pretty passionate about. And I would just open this up now to any questions that you may have.
We did get a question in here. One person asked, do you do press fit replacements?
We do. We do. Press fit is a way that the replacement fits in the bone instead of using cement or glue. And I think it works really well for patients who have good bone. If the bone is so soft that when we push into it, it starts to settle. In those cases, we use cement. But what we're finding that is now with better bone health, more and more patients can have a press fit replacement. And there's pros and cons. So we try to decide what's right for you, but we do a lot of press fit replacements as well.
Another question, can you do both knees at the same time?
You can do both of them at the same time, but we've sort of moved away from that. That was something we did really frequently in the past, but we found out a couple things by really studying those patients. One is that recovery is a lot harder. It's not the same as having just one knee at one time and the other at the other, and adding that together. It's extra hard because you just don't have a good leg to stand on. There's a slightly higher risk that you're going to have blood clots because you can't get around that well. So it's got to be for the right reason and the right patient who's in the right health. Otherwise, sometimes we would end up doing more harm than good, but we do it sometimes.
We got a few more questions here. Can you speak a little about the recovery looks like for knee replacement? What will my rehab look like in the days following surgery?
Yeah, so that's a really good question. I think in the past, if we go back 10, 15 years, people would have a knee replacement. They may be in the hospital for 2 or 3 weeks. We may not get them up right away. We may not let them bear weight at that time. And that was the wrong answer, And so then the pendulum kind of swung back to let's do therapy right away and let's get people into physical therapy as soon as possible. And I think that was a little too much too, because we had people with more swelling and more pain. So what I typically do is that for the first week at home, I just want you walking. We're going to give you exercises to do at home, but I don't want anybody forcing this knee in either direction. Trying to get it straight or trying to get it bent. Nobody needs to be forcing it. It should be able to get straight, and it should be able to bend at the time of surgery, or else we didn't do a great job for you. And so we want to sort of let you do your exercises on your own at first, and then usually somewhere between 7 to 10 days after surgery, I get people into therapy because I do think it's good to have a coach with you to help you through some of this. Most people go to physical therapy for somewhere between 4 and 8 weeks. It just depends on how well you're coming along and also how bad was the problem beforehand. People who are extremely stiff before surgery, they need more therapy afterwards. Folks who have really good range of motion before surgery, they may not need it for as long. So, what I tell patients is that usually at your first visit, 3 to 4 weeks out from surgery, most patients tell me, boy, I don't know that I'm better. I'm either the same as I was before or I'm a little worse. My knee feels different. It doesn't hurt like it did before, but it still hurts. And, the second visit, which is about 6 to 8 weeks out, that's when patients really sort of start to open up and say, okay, I'm better than I was, and I can see that every week is getting a little better than it was before, but it's somewhere between 3 months and a year before people are really happy that they did this and are recommending it to their friends and things like that. And folks who need both knees done, oftentimes they get one side done, and then within 4 to 6 weeks, they're saying, okay, I'm ready for the other side. I'm not as good as I'm ever going to be with the one that had surgery, but I can tell I'm headed in the right direction. I feel a lot better. I'm ready. And so, oftentimes that's when we can take the next step if we needed to.
Thank you. Another one. How does osteopenia impact knee replacement?
Yeah, very good question. So, somebody earlier asked about press fit knee replacements, and that's the idea of, instead of using glue on the bone, that we're sort of shaping the bone to fit the replacement perfectly, and then we're pushing these two parts together so that your body kind of grows onto this replacement, and it's really kind of stuck in there until that happens. When you have osteopenia, it's not a great idea to force that, because what can happen is either we can cause a break during surgery, or we get these two parts to fit together, but then after a while they start to settle. So in those cases, oftentimes we use some special replacements that are a little bit longer or shaped a little bit different, that are supposed to keep them from wiggling in the bone or working loose, and give us more space for cement. And then we put cement on the bone and on the replacement and put those two parts together. The cement is really strong, and it's been around for more than 50 years. We know that this stuff works really well. They use it in teeth and all over the body, and it works really well. But the cement, being as strong as it is, it kind of spreads into the osteopenic bone, and takes up the spaces that can form when bone gets brittle. And so it really helps shore up the strength of the bone around the replacement. And so it gives us both the benefit of sticking the replacement to the bone, but also helps the bone get a little bit stronger as well. So that's what we do for osteopenia.
Okay, great. And kind of on the same path, a question is, I'm allergic to bone cement. Can you tell before surgery if my bone is good enough?
We can get an idea of it. And what we often do in those situations is that we send people for allergy testing, and we figure out exactly what kind of cement are you allergic to. And then we try to have the other kinds on backup in case we needed it. So we would first look at your x-rays, and we would check your bone density and make sure, yeah, you might not even need any cement. But then we would also have a backup plan of, if you're allergic to it, how do we find a replacement for you that we may not use all the time, but in those situations we have it on hand.
Great. There's a lot of great questions here. Last two here. What does recovery look like for hip replacement? When would I be able to return to work as an office manager?
Yeah, that's a great question. So, desk work, really, people can go back very quickly. If you work remotely, I think within a week is probably reasonable. If you have to go into the office, I think 3 weeks would make me feel better. I want to make sure that your incision is healed, that it's not having any problems, and then when you're out in the world, that there's not something that's going to get into this wound, cause any problems for you. So, in terms of office work, I think you can go back within 2 to 3 weeks, is typically reasonable. But hip recovery has come just a long way, where people used to be in the hospital for a long time. Now I would say that the majority go home the same day, depending on their overall health. But most people go home the same day and are really happy, and are getting around, to where, earlier I had talked about knee replacement, that at the first visit, most patients are saying, I'm about the same as I was before surgery. With hip replacement, at the first visit, which is 3 to 4 weeks out, most patients say I'm substantially better than I was. I still have I'm still healing up from surgery, but I can tell I'm way better than I was.
All right, last question. Do you use a CPM machine during recovery?
So I don't do it routinely. There are some patients that need it. Some folks who are extremely stiff beforehand, I think it's good for. But the CPM machine was something that we used a lot in the past, and we found out some pretty interesting things from it. One was that people had really good bend with the CPM machine, but they weren't getting their knee all the way straight. And straight is extremely important after knee replacement surgery, because if you can't get your knee straight, you're going to limp. And if you limp, you're going to get tired faster, and you're not going to be very happy with it. And so the thing about a CPM machine is it can't get the knee all the way straight just because mechanically, the way that thing slides back and forth, it just can't get this knee all the way straight. And so when patients were relying on it, they would get good bend, but they wouldn't get straight. And then the other thing we found is that if we look at patients 6 weeks out, um, uh, everybody is doing pretty good when it comes to bending their knee, with or without a CPM machine. So we found that it was maybe hurting us more than it was helping. I will use them for patients, like I said, who are really stiff before surgery. And there are some patients that want it. They say, look, I've had a good experience with this in the past, or I know somebody that has, and I want to use it. And in that case, I'm happy to do so. We just keep a closer eye on you to make sure you're getting all the way straight also. So your follow-up, we may see you at 2 weeks and 4 weeks and 6 weeks to make sure we're not getting behind the eight ball. But that's just another way that we, personalize this treatment plan for you.
All right. Well, that's all the questions. Thank you very much for the knowledge today.
Of course, it's my pleasure to be here, and I hope that this was informative and everybody enjoyed it. And come see us at Columbia Orthopaedic Group. I would be thrilled to be able to be part of your care.
Thank you very much. And thank you guys for attending. We'll send out a recording of this in the next few days. And if you have any questions or want to book an appointment, visit columbiaorthogroup.com. Thanks again for attending.